Today's webinar on plan design is being presented by Ina Rubin from the Center on Budget and Policy Priorities. And with that, I'll turn it over to Ina.
Thank you so much, Kyle, and hello, everyone. During today's webinar, we'll be delving into how health insurance plans work. We'll be defining some common health insurance terms, and we'll walk through the kinds of costs individuals may encounter when using their health insurance plan. Our next webinar, scheduled for next Tuesday, October 5th, will build on the information you'll learn today, and it will help prepare you to explain complex health insurance terms to your clients in a way that they'll understand. That webinar will also provide useful tips for helping people navigate the plan selection process. So let's start with the basics by going over the elements of qualified health plans, also known as QHPs. First, what is a QHP, right? Well, a qualified health plan, or QHP, is an insurance plan that meets the standards and includes the consumer protections outlined in the Affordable Care Act. QHPs must be certified by the Federal Health Insurance Marketplace or a state-based marketplace. QHPs must include coverage for pre-existing conditions, and they must cover the 10 essential health benefits. QHPs must also have cost-sharing limits that follow federal regulations, and they must not have any annual or lifetime benefit limits. Now that we know what a QHP is, let's talk about the basic elements of QHPs, starting with those 10 essential health benefits. So every QHP is required to cover 10 kinds of healthcare services. These services are known as essential health benefits, and they include preventive care services, ambulatory services, which is just outpatient medical care, hospitalizations, laboratory services, prescription drugs, emergency services, maternity care, mental health and substance use disorder services, rehabilitative services, and pediatric services. So as you can see, QHPs are designed to provide really comprehensive coverage. Of course, limitations do apply. So for example, while QHPs are required to cover prescription drugs, they're not required to cover every single prescription drug currently available. The next basic element of QHPs is the plan network. Insurance companies establish contracts with physicians, hospitals, and pharmacies to provide healthcare services to their plan enrollees. These contracted providers are the plan's network. Providers the insurance company doesn't have a contract with are considered out of network. Now, there are certain types of plans that will cover services a plan enrollee receives from an out-of-network provider. But in those instances, the enrollee will usually have to pay more out of pocket than they would if they went to an in-network provider. While other types of plans won't cover any services received from an out-of-network provider, which means that the enrollee will be responsible for 100% of the costs for services they receive from an out-of-network provider. There is an important exception here for care provided in a medical emergency. In the case of a medical emergency, all plans are required to cover out-of-network care in the same way they would cover in-network care. It's also really important to know that each plan has its own unique network, and this is even true among plans offered by the same insurance company, which is why it's always crucial to check each individual plan's network when comparing plan options. So there are 4 types of QHPs you may encounter, though not all 4 types are available in all areas. Those 4 types include HMOs, EPOs, PPOs, and POS plans. So one of the key differences between this alphabet soup of plan types is the way in which the network functions in each of these 4 categories of plans. While most people may be familiar with HMOs and how HMOs and PPOs work, EPO and POS plans are kind of just a hybrid between HMOs and PPOs, but in slightly different ways. So let's talk about HMO and POS plans first. Both HMO and POS plans require an enrollee to select one in-network doctor as their primary care provider. If that enrollee wants to go to a specialist, they'll need to get a referral from their primary care provider first. Another way in which HMOs and POS plans are similar is that they both typically have narrow networks, which means that they have fewer in-network doctors and hospitals to choose from as compared to EPO and PPO plans. though POS plans may have slightly more choices than HMO plans. Next, we have EPO and PPO plans. A key similarity between these two types of plans is that the enrollees typically aren't required to select a primary care provider, and they can go to any in-network doctor or specialist without needing to get a referral first. Both EPO and PPO plans will have broader networks than HMO and POS plans, which means enrollees will have more in-network doctors and hospitals to choose from. Now, let's take a look at how each of these types of plans functions when it comes to out-of-network services. So HMO and EPO plans don't cover any services an enrollee receives from an out-of-network provider, except in cases of a medical emergency. While PPO and POS plans do cover services received from out-of-network providers, but the enrollee will have to pay more out of pocket than they would if they went to an in-network provider. The next element of QHPs is the formulary. As I mentioned earlier, while QHPs are required to cover prescription drugs, they're not required to cover every single prescription drug available. A formulary is basically just a list of medications that an insurance plan will cover, and medications not listed in the formulary are generally not covered by the plan, although some exceptions do apply here. So the formulary splits up covered medications into categories or tiers to indicate the level of coverage the plan provides and the portion of the cost the enrollee will have to pay for various medications. The higher the tier of the medication, the more the enrollee will likely have to pay. Generic medications are usually the lowest tier, which means the enrollee will pay the least for these medications. Two more basic elements of QHPs are premiums and cost-sharing charges. Premiums are the monthly cost a person must pay for their health insurance plan, regardless of whether they use healthcare services. Premiums basically function like a subscription service, like Netflix, for example, meaning that the premium must be paid every month or the person's plan may be terminated. Cost-sharing charges, on the other hand, are the costs a person pays when they actually use healthcare services. So now let's go beyond the basics and dive into what cost-sharing charges are and how they work. There are three types of cost-sharing charges: deductibles, co-payments, and co-insurance. A deductible is the amount an enrollee must pay out of pocket for healthcare services before their insurance plan starts paying for a portion of healthcare costs. The deductible resets every plan year. So an enrollee who met their deductible in 2021 will need to meet their deductible again in 2022. The deductible could also reset if someone changes insurance carriers during the plan year, or in some cases, if they change plans with the same insurance carrier during the plan year. Co-payments are a set dollar amount an enrollee must pay when they receive healthcare services. For example, a plan might have a $25 copay an enrollee must pay when they see their primary care doctor. Co-insurance is similar to a co-payment, except that with co-insurance, the enrollee must pay a percentage of the total cost for healthcare services they receive instead of a fixed dollar amount. For example, a plan might have 30% co-insurance for specialist visits, meaning the enrollee would pay 30% of the total cost for their visit to a specialist. In some plans, certain services may be covered before the deductible is met, which is sometimes referred to as first dollar coverage. When comparing plan options, look in the summary of benefits for terms like deductible does not apply or not subject to deductible. You may also encounter plans that have a separate deductible for prescription drugs. And under the ACA, preventive care services are required to be covered without any cost sharing, which means no deductible, co-payment, or co-insurance charges. Preventive care services include such things as well woman visits, screenings for illnesses such as cancer, diabetes, and hypertension, immunizations, and FDA-approved contraceptives for women. The ACA put into place a really important safety net when it comes to cost-sharing charges, known as the maximum out-of-pocket limit. This limit protects people from catastrophically high out-of-pocket costs by putting an annual cap on the amount of cost-sharing charges an enrollee could pay in a year. Importantly, the annual cap is not like the deductible because it's not the amount an enrollee must spend each year, it's the maximum an enrollee could spend in a year. All of the out-of-pocket costs an enrollee pays, including the deductible, co-payments, and co-insurance, count towards this out-of-pocket limit. The monthly premiums do not count. So if an enrollee reaches their plan's out-of-pocket limit, then the plan will have to pay for 100% of all covered healthcare services the enrollee receives without any copays or co-insurance charges, as long as the enrollee goes to an in-network provider. The maximum out-of-pocket limit is set by the federal government each year. For 2022, the out-of-pocket limit is $8,700 for an individual and $17,400 for a family of 2 or more. While some QHPs will have lower out-of-pocket limits, no QHPs will exceed the federally set limits. So now let's take a look at an example of how the deductible and out-of-pocket limit work. This is Carl, and he enrolled in an HMO plan for 2021. His plan has a $3,000 deductible and a $7,000 out-of-pocket limit. Carl had some pretty high medical costs this year, which added up to $40,000. Unfortunately, he was hospitalized at the beginning of the year. His hospitalization cost $16,300. Since the plan Carl was enrolled in has a $3,000 deductible and hospitalizations are subject to the deductible in this plan, Carl had to pay the first $3,000 of his hospitalization bill in order to meet his deductible. Now, the remaining hospitalization bill was $13,300. Since Carl paid $3,000 and met his deductible, the plan started paying for a portion of the healthcare services Carl received. In this case, the plan paid for 70% of the remaining $13,300, and Carl was responsible for paying 30% of the bill, which, as we talked about earlier, is known as a co-insurance charge. After Carl paid $4,000 in co-insurance, he reached his plan's annual out-of-pocket limit, which is $7,000. Now, all the rest of the in-network healthcare services Carl receives this year, which total $23,700, will be completely covered by his plan, and he won't have to pay anything else out of pocket. So that means no more co-payments or co-insurance charges. Now let's go a little deeper into how cost sharing works by looking at one specific plan from Miami-Dade County, Florida. This plan has a $3,000 deductible and a $7,000 out-of-pocket limit. It also looks like this plan covers some healthcare services before the deductible is met, while other services are subject to the $3,000 deductible. In this plan, generic drugs, primary care visits, and specialist visits appear to not be subject to the deductible, but they do have a copayment. While emergency room visits are subject to the deductible and have a copayment after the deductible has been met. But we'll want to confirm all of this information by looking at the plan's official summary of benefits and coverage, which you can find by first clicking on the Plan Details button on the left. When you're on the Plan Details page, you'll want to click on the Plan Documents and then on Summary of Benefits. This will open up the plan's official Summary of Benefits and Coverage, or SBC. On the SBC, you'll be able to find more detailed cost-sharing information for specific types of healthcare services. As you see, this plan's SBC indicates that office visits, certain prescription drugs, and ambulance rides are not subject to the deductible. The SBC also shows us that ER visits and hospitalizations are subject to the deductible, with a $500 copayment and a $900 copayment, respectively, after the deductible has been met. So let's revisit Carl now to get a better picture of how these different types of cost-sharing charges would work if he enrolled in this specific plan. What we're going to do here is break down the $40,000 in medical expenses that Carl had this year into each individual healthcare service he received to get a more detailed understanding about how this plan works. And keep in mind that all of the services that Carl receives are from in-network providers. So at the beginning of the year, Carl was feeling unwell and had to take an ambulance to the emergency room. The ambulance ride cost $1,000, and as we saw in the SBC, this plan covers ambulance rides before the deductible is met, but with a $200 copayment. So Carl will have to pay $200 for the ambulance ride, and that $200 copayment counts towards his out-of-pocket limit. Carl's visit to the emergency room costs $4,000, and emergency room visits are subject to the deductible in this plan. This means that Carl will have to pay $3,000 out of pocket towards his emergency room bill in order to meet his deductible, which he's now met. This plan also requires a $500 copayment for emergency room visits after the deductible has been met. This means that Carl will have to pay an additional $500, which makes his total cost for the emergency room visit $3,500. That entire amount counts towards a $7,000 out-of-pocket limit. Carl ends up being admitted to the hospital for some tests. So he has a one-day hospitalization that costs $7,000. According to the SBC, this plan has a $900 copayment per day for hospitalizations, which also counts towards his out-of-pocket limit. While he's at the hospital, Carl has a laboratory test done, which costs $3,000, and his copayment for the test is $200. He also has x-rays done, which cost $2,000 and have a $300 copayment. So we're adding another $500 towards his out-of-pocket limit. And as you can see, he's getting pretty close to reaching the annual out-of-pocket limit for the year. When Carl is released from the hospital, he's prescribed 3 generic medications. Generic drugs have a $20 copayment in this plan, which means that his 3 medications will cost $60 per month. So over the course of the year, Carl will have to pay $720 for his 3 medications. Finally, Carl has to see 2 different specialist doctors every month for follow-up care. Specialist visits have an $80 copayment. So he would have to pay $160 in copayments every month, but only until he reaches the out-of-pocket limit, which means that once he's paid another $1,180 in copayments, he will have reached his out-of-pocket limit for the year. So any additional healthcare costs he has will be paid for by the insurance plan as long as Carl stays in network. So Carl doesn't have to make any more copayments. So I know that was a lot, but let's do it one more time to make sure it sticks. We're going to take a look at a plan that is structured quite differently from the last plan. As you saw, the last plan covered most services before the deductible was met. This plan, on the other hand, doesn't cover any services until the deductible is met. This plan also has a higher deductible of $5,000, but the annual out-of-pocket limit is the same at $7,000. Also important to note is that this plan has co-payments for some services and co-insurance for other services. And again, Carl goes to in-network providers for all of these services. Carl had $40,000 in medical expenses this year and received the exact same healthcare services we just covered. So we're going to run through how a plan that's structured this way would work for Carl and see if you can spot the main difference. At the beginning of the year, Carl was feeling unwell and had to take an ambulance to the emergency room. The ambulance ride costs $1,000, and this plan doesn't cover ambulance rides before the deductible is met. So Carl will have to pay the full $1,000 for the ambulance ride. That $1,000 counts towards his deductible and annual out-of-pocket limit. Carl's visit to the emergency room costs $4,000, and emergency room visits are also subject to the deductible in this plan. This means that Carl will have to pay the entire $4,000 bill out of pocket. But now, after paying for the ambulance and the ER visit, he's met his deductible for the year in one day. Again, Carl is admitted to the hospital for some tests. His one-day hospitalization costs $7,000. This plan has a 20% coinsurance charge for hospitalizations after the deductible has been met. So 20% of $7,000 is $1,400, and that is how much Carl has to pay for his hospitalization. While he's at the hospital, Carl has a laboratory test done. His copayment for the test is $200. He also has x-rays done, which have a $300 copayment. These $500 in copayments are counted towards his out-of-pocket limit. And as you can see, he's almost reached the limit, the out-of-pocket limit for the year during this one hospitalization. When Carl is released from the hospital, he's prescribed 3 generic medications. Generic drugs have a $20 copayment, which means 3 medications per month will be $60. But because he's already paid $6,900 towards his out-of-pocket limit of $7,000, he only has to pay $100 more, or the equivalent of filling 5 generic prescriptions to meet his annual out-of-pocket limit. Then the insurance plan will begin to completely cover all of his healthcare services without any more copayments or coinsurance charges, as long as Carl goes to in-network providers. So remember those 2 different specialist doctors he has to see every month for follow-up care? He doesn't have to pay anything at all for those visits because he's reached his $7,000 out-of-pocket limit for the year. So the answer to the question I asked earlier about the main difference between the way these 2 plans that we've just covered would work is the length of time over which Carl will have to pay for cost-sharing charges. Under both plans, Carl ends up paying $7,000 for his healthcare services this year because that's the out-of-pocket limit for both plans. But in the first plan, his payments towards that $7,000 are mostly spread out over the course of the year through copayments. While in this plan, Carl will have had to pay almost the entire $7,000 right at the beginning of the year when he was hospitalized. When a family of 2 or more people enroll in a plan, cost-sharing charges get a little more tricky. First, the deductible and maximum out-of-pocket limit for a family are double what the amount is for an individual. Family deductibles come in 2 forms: aggregate, which you can think of as just a family deductible, and embedded, which you can think of as an individual plus family deductible. A plan with an aggregate family deductible requires the family to meet their entire family deductible before their plan begins to pay for the healthcare services of any family member. On the other hand, a plan with an embedded deductible, which is individual plus family, will require each family member to meet a smaller deductible, which is counted towards the larger family deductible. Once a family member meets their individual deductible, the plan will begin to pay for a portion of that family member's healthcare costs. But the plan will not pay for the healthcare costs of any other family member until they reach their own individual deductible, or the family reaches their overall family deductible. But as we talked about before, the out-of-pocket limit safety net also applies to family plans. So each family member is protected by the individual maximum out-of-pocket limit of $8,700 in 2022, which means that even though the family out-of-pocket limit may be much higher than $8,700, no individual family member could pay more than $8,700 in out-of-pocket costs in 2022. So here's an example of how an aggregate family deductible would work. The Rashid family enrolls in a plan with an aggregate family deductible of $12,000. And as a reminder, the individual out-of-pocket limit is $8,700 for 2022. Between January and September, Danielle receives $1,000 in healthcare services. Marcus receives healthcare services that add up to $9,000, while Craig receives $2,000 in services. In an aggregate family plan, the Rashid family would have to pay almost all of the costs for healthcare services they received so far out of pocket, totaling $11,700, which would go towards the family deductible. Now, the reason the family doesn't have to pay the full $9,000 for services Marcus received is because the individual out-of-pocket limit is $8,700, which means that even though they wouldn't have met their family deductible yet, the plan will begin covering 100% of Marcus's healthcare costs moving forward because he will have met the individual out-of-pocket limit for the year. And since the Rashid family will have paid $11,700 towards their $12,000 aggregate family deductible, once either Danielle or Craig pays $300 for healthcare services, the family will have met their family deductible, and the plan will begin to pay for a portion of the costs for services for Danielle and Craig as well. But what if the Rashid family decided to enroll in a plan with an embedded individual plus family deductible instead? In this plan, the family deductible is also $12,000, but each individual family member's deductible is $6,000. How this would work is that the Rashid family would pay $6,000 out of pocket for Marcus's healthcare services. And then Marcus will have met his individual deductible, which means that the plan will begin paying for a portion of Marcus's healthcare services moving forward. The plan wouldn't pay for Craig's or Danielle's healthcare services yet until they meet their own individual deductibles, or until the family meets their overall $12,000 family deductible. So the Rashid family will have to pay out of pocket for the services both Craig and Danielle have received so far. So we're going to complicate things just a little more and talk about how cost sharing works for in-network services versus out-of-network services. As we discussed earlier, PPO and POS plans will cover services an enrollee receives from an out-of-network provider, but the enrollee will have to pay more out of pocket for those services than they would if they went to an in-network provider. It's important to note that PPO and POS plans will also generally have a separate, much higher deductible for out-of-network services. So when an enrollee pays for out-of-network healthcare services, those costs don't count towards meeting their in-network deductible. Also important is the fact that the maximum out-of-pocket limit set by the federal government does not apply to out-of-network healthcare costs. Even though some plans may have an out-of-pocket limit for out-of-network services, that limit will be much higher than the in-network out-of-pocket limit, which is required to comply with federal standards. So in this example, this plan has separate deductibles for in-network and out-of-network services, and there's no out-of-pocket limit for out-of-network services, which means that the enrollee would have to pay, would not have a cap on how much they would pay in a year. The enrollee in this example would pay a $25 copayment if they went to an in-network primary care doctor, but if they go out-of-network, they'll be responsible for 50% coinsurance of the allowable charges. So let's walk through how this would work. The person enrolled in this plan goes to see 2 different doctors, and each doctor charges $200 for the visit. You'll recall that in-network providers are doctors and hospitals that have a contract with the insurance company. Well, those contracts set the amount an insurance plan will pay in-network providers for specific services. This set amount is known as a plan's allowed amount. What this means for this person's in-network visit is that even though the doctor charged $200 for the visit, because the plan's allowed amount for the visit is $100, the doctor only expects to be paid $100, and the enrollee is only responsible for their $25 copayment, while the plan pays the other $75. But since the out-of-network doctor doesn't have a contract with the plan, that doctor expects payment for the full cost of the visit, which is $200. How this would work with the out-of-network doctor is that the plan would pay $50 towards the $200 charge, because that is 50% of the allowed amount, which remember is $100. The enrollee would be responsible for their 50% coinsurance charge of the allowed amount, which is also $50, plus the difference between the allowed amount and the actual bill, which is $100. So the enrollee would end up paying $150 for the visit. When an enrollee is responsible for paying the difference between their plan's allowed amount and the actual bill, that's known as balance billing. And on the topic of balance billing, a new law was passed last year called the No Surprises Act, which bans balance billing in certain situations. When an individual receives out-of-network emergency care or is treated by an out-of-network provider at an in-network facility, the new law says that the individual can only be charged in-network cost sharing. Now, the individual can sign away their balance billing protections in some cases. For example, a specialist can ask a patient to sign a consent form that says they agree to pay whatever the specialist wants to charge with little or no reimbursement from the insurance plan. Some types of out-of-network providers at in-network facilities cannot balance bill or ask someone to give up balance billing protections, meaning the patient will always pay in-network cost sharing. This includes anesthesiologists, radiologists, laboratory technicians, among others. So, for example, if someone chooses an in-network hospital for spine surgery, but the radiologist needed for immediately prior to the surgery is out of network, the patient will only be responsible for the in-network payment for the out-of-network radiologist because the patient was at an in-network facility. Now, different rules and additional benefits are available to members of federally recognized Native American tribes and Alaska Native Claims Settlement Act Corporation shareholders, which we'll refer to as AIAN individuals because it's much shorter. So they can enroll in or change marketplace plans each month without needing to qualify for a special enrollment period. AIAN individuals between 100% and 300% of the federal poverty level who qualify for premium tax credits will have $0 cost sharing plans available to them, which means that they would have no deductibles, no co-payments, and no co-insurance charges when using in-network covered healthcare services. And even some out-of-network care is available with zero cost sharing. For AIAN individuals with income below 100% FPL or above 300% FPL, there is a limited cost sharing plan available in which an enrollee pays no cost sharing to receive services but from an Indian health services provider or from another provider if referred to them from an Indian health services provider. So now let's talk about the part you've all been waiting for, actuarial value. And before your eyes glaze over, I'll just say that it's actually a really interesting and important component of health plan design. First, what is actuarial value? Well, simply put, actuarial value, which I'm going to refer to as AV from now on because it's easier to say, it's just a way to compare the overall generosity of plans by indicating what percentage of overall healthcare costs a plan will pay on average, and what percentage the enrollee will be responsible for. If a plan has low AV, then the enrollee will have to pay more out of pocket. The higher the AV a plan has, the less the enrollee will have to pay out of pocket. Marketplace plans are organized into 4 different AV levels, represented by 4 types of metal: bronze, silver, gold, and platinum. Each metal level is associated with a different AV. It's important to know that AV shouldn't be confused with coinsurance because AV does not represent what the plan would pay for a particular individual enrolled in the plan, since an enrollee's actual out-of-pocket costs depend on the medical services they receive. Meaning that if a plan has 70% AV, that doesn't mean that the enrollee will have to pay 30% coinsurance charges for services, because as we talked about earlier, different plans have different cost sharing charges for different services. Instead, AV represents the average a plan will pay across a standard population. Also, AV and metal levels are not meant to represent the quality of the plan, the quality of the care provided under the plan, or the size of the plan's network. Because higher AV plans are more generous and have lower out-of-pocket costs, the premiums for those plans are going to be higher. Put another way, as AV increases, so do premiums. As you see in this chart, bronze plans are associated with 60% AV, silver have 70% AV, gold have 80%, and platinum have 90% AV. Which means that, generally speaking, bronze plans will have the lowest premiums and platinum plans will have the highest premiums. But the actual cost sharing charges plans differ widely, even among plans at the same AB level, which is why it's always really important to take the time to compare plan options side by side. And we have a resource that can help you do just that. Our plan comparison worksheet allows you to compare up to 4 plans side by side. You can download it and fill it out on your computer, then print the completed worksheet for the client or email it to them. And this worksheet is available in 8 languages on our website. So let's walk through a couple of different plans available in Dane County, Wisconsin that will help illustrate how AB impacts cost sharing. First, here's a bronze plan with 60% AB. Next is a silver plan with 70% AB. Then we have a gold plan with 80% AB. And finally, a platinum plan with 90% AB. As you can see, the higher the AB is for a plan, the higher that plan's monthly premium will be. And the lower a plan's AB is, the higher the deductible and out-of-pocket costs will be. So the bronze plan with 60% AB costs about $170 less per month than the platinum plan, but the deductible is $8,000 higher than the platinum plan. To further illustrate the difference in cost sharing charges across AB levels, let's look at the co-payments and co-insurance of these plans. So comparing the cost sharing charges for a visit to a primary care doctor, you'll see that the co-payments differ pretty widely depending on the AB level of the plan. For someone enrolled in this bronze plan, their visit to the primary care provider will cost them $125, which is their co-payment for the visit. While a person enrolled in the platinum plan who goes to see the same primary care doctor for the same service would only pay $20 as their co-payment. Now that you know what cost sharing charges are, let's talk about financial help that's available on the marketplace that reduces cost sharing charges for low-income individuals and families, also known as cost sharing reductions. Cost sharing reductions, or CSRs, increase the AB level of silver plans by reducing the out-of-pocket costs an enrollee has to pay for medical care, and also reducing the out-of-pocket limit for enrollees. CSRs are available to people with income up to 250% FPL. But it's very important to know that CSRs are only available in silver level plans. So if someone is eligible for a CSR, but enrolls in a bronze plan instead of a silver plan, their cost sharing won't be reduced, and they'll be missing out on a subsidy they're eligible for. There are 3 different levels of CSRs available in silver plans, and these levels are based on a person's income. Sorry about that. Let's see, so the lower a person's income is, the higher the level of CSR they'll be eligible for, which means that people with very low income will have CSRs substantially increase the AB level of the silver plan they select. Individuals with income over 250% FPL, or over about $32,000 per household of one, are not eligible for CSRs. So the AB for silver plans will remain 70% for them. Individuals with income between 200% FPL and 250% FPL, which is about $26,000 to $32,000 for a household of one, will be eligible for the lowest CSR amount. This will increase the AB of silver plans available to them from 70% to 73%. This will also reduce their out-of-pocket limit for the year down to $6,950. So the most they could pay in 2022 for healthcare services would be $6,950 rather than $8,700, which is the out-of-pocket limit for people who are not eligible for CSRs. Now, individuals between 150% FPL and 200% FPL, which is about $19,000 to $26,000 for a household of one, will be eligible for the second level of CSRs. The second level of CSRs will increase the AB of silver plans available to them from 70% to 87%, which means that they'll be able to pick a silver plan with an AB that's almost as high as a platinum plan. The second level of CSRs also reduce their out-of-pocket limit to $2,900. And individuals with income below 150% FPL, or about $19,000 for household of one, will be eligible for the highest level of CSRs that will increase the AD level of silver plans available to them from 70% to 94%, meaning that they could enroll in a silver plan with a higher AD than a platinum plan. So here's an example of what one silver plan available in Cook County, Illinois looks like with different levels of CSRs applied. Without any CSR, this plan has a 70% AV with a $6,500 deductible and an $8,400 out-of-pocket limit. If someone is eligible for the lowest level of CSR, the AV on the same plan goes up to 73%. The deductible is cut almost in half, reduced down to $3,850, and the out-of-pocket limit is lowered to $6,500. At the second level of CSR, this plan's AV goes up to 87%. The deductible is further reduced down to $950, and there is a $2,250 out-of-pocket limit. And at the highest level of CSR, the AV goes up to 94%, which eliminates the deductible entirely and cuts the out-of-pocket limit down to $1,400. Another way CSRs impact cost sharing is by reducing a plan's co-payments and co-insurance. So looking at the different levels of CSRs for this plan, you'll see that a person enrolled in this plan without a CSR will pay a $35 co-payment to see a primary care doctor. The co-payment for that visit goes down as the CSR level goes up. So their co-payment with the lowest level of CSR will be $25. The second level of CSR would be $5 co-payment, and the highest level of CSR would have no co-payment at all. So let's look at another silver plan in Cook County, Illinois. First, do you notice that this plan has a different name at each CSR level? Well, this is something you might encounter every now and then. How you can tell that all four of these are actually the same plan, just with a different name at each different level of CSR, is by looking at the plan ID, which is listed just below the plan name. So here you'll see the same basic structure as we saw in the last slide. The lower a person's income is, the higher their CSR is, which results in the highest AV and lowest cost sharing charges for people with very low income. And as we discussed in the last section, the actual cost sharing charges plans have can differ widely, even among plans at the same AV level. So let's compare the two plans we just looked at with the second level of CSRs, which means both plans have 87% AV. As you can see, the Better plan has a lower deductible and a lower out-of-pocket limit than the Bright Healthcare plan. But the Bright Healthcare plan has lower co-payments and co-insurance than the Better plan. For example, the Better plan has a $10 co-payment for generic drugs, while the Bright Healthcare plan has no co-payment or co-insurance for generic drugs. Remember, though, that these cost-sharing charges are only applicable for in-network services. Since these are both HMO plans, out-of-network services wouldn't be covered at all, other than in cases of medical emergency. And before we go on to the next section, I just want to remind people, if you want to ask a question, just type it into the Q&A box. So now that we've talked about what QHPs are, let's talk a little bit about so-called alternatives to QHPs, or skimpy plans. Skimpy plans come in a number of different forms, including short-term plans, association health plans, healthcare sharing ministries, indemnity plans, among others. The one thing all of these different types of skimpy plans have in common is that they are not QHPs, which means that they don't have to meet the standards outlined in the Affordable Care Act, and they're not certified by the Federal Health Insurance Marketplace or state-based marketplaces. Most importantly, they don't have to include any consumer protections, meaning that they can charge higher premiums based on gender and pre-existing conditions. They can deny coverage based on pre-existing conditions. They can impose annual and lifetime coverage limits. They can deny claims for pre-existing conditions, and they can exclude essential health benefits. All of which is to say, these aren't health insurance. They're junk. And these skimpy plans may look cheap, but they can very well come at a catastrophically high cost for people who actually need healthcare services. The companies and insurance brokers who sell skimpy plans have been found to sometimes engage in deceptive marketing and sales tactics, leading people to think that they're insured until they actually need healthcare services. Only then do they find out about all the exclusions and restrictions these types of plans include. Some of the key features of one specific type of skimpy plan, known as a short-term limited duration plan, include generally include excluding coverage for pre-existing conditions. And these insurers may consider a condition pre-existing even if it wasn't previously diagnosed or treated, and even if the enrollee was not aware of the condition. Insurers may conduct what's known as a post-claims underwriting or claims eligibility review, in which the insurer investigates the health history of an enrollee with costly claims in order to try to find a link to a pre-existing condition so that they can refuse to pay for the healthcare services they received. Also, people with pre-existing conditions may be denied a policy outright. Short-term plans are not required to cover essential health benefits, and often they don't cover things like prescription drugs, maternity care, mental health and substance use disorder services, among others. Short-term plans can impose overall limits on plan benefits. They can impose lifetime limits and per service limits. They also don't have to limit cost sharing, meaning that they can ignore the federal out-of-pocket limit safety net that we talked about earlier. Sometimes a short-term plan may be designed to look like a comprehensive health plan with a premium, a deductible, and a provider network, but that doesn't mean it's actual insurance. And really importantly, short-term plans don't count as minimum essential coverage. So when the plan ends or an enrollee wants to cancel their plan, they aren't eligible for a special enrollment period, and they may have to remain uninsured until the next open enrollment period. Now, many states have the authority to set their own standards for short-term plans and other skimpy plans. And some states have strengthened their protections against short-term plans. But unfortunately, not all states have the authority to conduct oversight of skimpy plans. And also, there is no federal oversight of short-term plans and other skimpy plans more generally. The federal marketplace allows insurers and brokers, including web brokers, to use their own websites rather than healthcare.gov to let people apply for and enroll in marketplace plans and receive subsidies. These are known as direct enrollment, or DE, and enhanced direct enrollment, or EDE websites. Direct enrollment websites send people to healthcare.gov for an eligibility determination and then send them back to the DE site for plan selection, while enhanced direct enrollment websites allow an insurer or broker to keep the person at the EDE site for the entire process without sending them to healthcare.gov. The use of DE and EDE sites can sometimes be problematic because some of the websites sell short-term plans and other skimpy plans. While federal rules bar these plans from being displayed alongside QHPs, some sites still heavily promote them. What's also concerning is that some DE and ED sites may even try to sell skimpy plans to people eligible for Medicaid instead of helping direct them to the right resources to enroll in Medicaid. As you can see, skimpy plans are a real problem, and an estimated 3 million people are enrolled in them right now. So you might be wondering what you can do to help people avoid the pitfalls of skimpy plans. The most important thing you can do is promote open enrollment and make sure to tell people that they're guaranteed to get real health insurance if they use healthcare.gov or your state-based marketplace. You can also promote special enrollment periods for people who may be facing coverage gaps during the year. And you should make sure you understand the risks of short-term plans and other skimpy plans so you can help people see past the low premiums of these plans and understand the high costs they may face down the road. And finally, you can serve as an advocate for your clients by tracking their experiences with these plans, informing them of their right to complain about wrongdoing, and helping them report fraud and misinformation to the state insurance regulators.
Just a little bit in closing here. As a reminder, we will be distributing the materials from today's presentation via email, and we'll post everything to the Beyond the Basics website. That's www.healthreformbeyondthebasics.org. The next part of this webinar series will cover plan selection strategies and is scheduled for next Tuesday, October the 5th at 1 p.m. Eastern, and that's 10 a.m. Pacific. You can register for upcoming webinars on the Beyond the Basics website under upcoming webinars. You can also find additional resources on the website, including reference charts, guides, and frequently asked questions. If you have any questions or need assistance, please email our Beyond the Basics contact email. Again, that's beyondthebasics@cbpp.org. And with that, we'll bring today's webinar to a close. Thank you again, everyone, for joining us today.